Yeah, sure. So this is a 45-year-old female who was found to have a serum creatinine of 1.6 at an annual checkup with her primary care physician, and she was asked to hydrate and repeat the kidney function test in 1 week, at which time her creatinine had worsened to 2.2.
Okay, that's a great place to stop. Do we know what her creatinine had been previously with that physician?
It had been within normal ranges. I don't have the exact value.
Okay, so now we need to have, it would be really nice to have somebody who is not um, a, who is not on the virtual morning report just for discussion purposes. So it would be wonderful if a couple of people could volunteer uh, to help us work through what you would do if you were in clinic. So that's really the big question. So Joshua had signed up. Is Joshua here?
I'm here, and I don't know the case.
Oh, good. Okay, so we'll start with that, and if there's someone else who'd like to join, just put your name in the chat. So for those of you who are students and soon to be interns, and for those of you who are interns, this is a fairly important problem in clinic. This is a classic outpatient problem. You just get routine labs, and someone now their creatinine has gone up to 1.6. What are the possibilities?
So first thing I think of is, has she started taking any new medications? Assuming she's been well.
You know, just for fun, Josh, just in case people don't know who you are, why don't you go ahead and introduce yourself?
Yeah, so I'm Josh. I'm a fourth year med student over here in Austin, Texas at Dell, applying med peds, and excited to be here for another wonderful BMP teaching case.
Okay. Sean, you can go ahead and erase everything except for the 2.2. We'll get to a full BMP later on. Okay, so the first thing you're thinking about is, could this be a med side effect? Okay, mm-hmm. What else?
Yeah, just kind of thinking out loud, what else has been going on? Has she been like totally healthy as far as she feels beforehand? Because being on nephrology right now, we start thinking everything has sort of been thinking about like what's the trend been, and also sort of what's in the urine as well. So I don't know what the causes of this over a such a short term would be, like especially over a week, but some sort of inflammatory process within the kidney is the first thing that comes to mind as to what that could be from.
Okay, let's see if we can come up with why someone would come in with a new creatinine 1.6 when it was previously normal, and it's just an annual checkup. She's not complaining of anything at this time. And the first thing that I thought of is, the last thing that I'd think about is hydration. It's hard. You really have to be quite volume contracted to get serum creatinine 1.6. Now, we're not told, and I don't know, Gerline, if you know whether this patient also had a BUN at that time.
I don't know what the BUN was at the time. We were just told when I was seeing her in the hospital that her creatinine had been high at her primary care doctor prior to presenting to the hospital.
Right. So I would be more impressed with the idea of just hydrate and come back if the patient also had an extremely high BUN, because that's what you'd expect of his volume contraction. So just, and obviously the retrospectoscope is such a great tool. We're always really great looking backwards, but I do have to question not collecting more data for a serum creatinine 1.6. Now, Josh suggested some things that he would have gotten. and he's on renal right now, so he's been thinking about these things. So what were the things that you would get at this point?
So for her, I just want to know what the rest of the BMP looked like, and then maybe also look at her urine, the macro and the micro.
So you'd like a urinalysis.
Yeah.
And so let's think about this. So it could be medication. So we have to get a medication history. It could be an intrinsic kidney disease. It would be really unusual unless we get more history, and this was just an annual checkup for this to be acute tubular necrosis.
Right.
Yeah. It could be an interstitial kidney disease.
Mm-hmm.
It could be something related to inflammatory process. You would think it'd be one of those things. 1.6 is actually pretty high. Norma asked the question, could this be a response to, and of course I have to say it, a strep infection? That could give you an acute problem. Does she have any complaints, or is this just a pure annual checkup? And what supports the fact that there's something going on is that the next week her creatinine is 2.2. So that's pretty concerning, right?
Yeah. And the thing when you were talking that I thought about was that it just based on her story, it doesn't seem to be pre-renal or post-renal at this time. So it makes me think of some sort of intrinsic problem with the kidney.
So it's worthwhile to think about post-renal, and you can be really, really surprised by post-renal. So in a 45-year-old woman, what kind of post-renal syndromes could she have?
Pregnancy.
Okay.
Mass.
So pregnancy, mass. What else? So let's think about post-renal anatomically. What's the most common cause of post-renal obstruction in anybody? Let's say men.
BPH.
Right, BPH. But let's say bladder. So how? And I have seen women who came in because of bladder obstruction. Why did they have bladder obstruction?
Either autonomic neuropathy or maybe
Exactly. That is exactly the point. So we'd want to know if she's diabetic. I actually had a woman come in with a creatinine of 8, and so I asked the team whether or not she was obstructed, and she did have diabetes. And they said no. She says she's passing urine fine. I said, did you check to see if she was obstructed? And went up and did a bladder scan, and she had over a liter in an atonic bladder. Put in a Foley catheter, and we no longer had renal disease. We had a different disease. Okay, going up above the bladder, you mentioned a mass. Mm-hmm. So the first assumption is, are there 2 kidneys, or is there just 1 kidney? And some people are just born with 1 kidney. So we're going to need to do an ultrasound and see whether or not there's 2 kidneys. But what could mess up the ureters?
Mass effect.
So mass effect. Okay, so we could give her uterine cancer. Could do that. Colon cancer could do that. Okay, what else? This is a classic morning report disease.
Lymphoma.
So lymphoma can do anything, yeah. Lymphoma is the great imitator these days. IgG4. And how does IgG4, what syndrome does that cause that causes ureteral obstruction?
The retroperitoneal fibrosis.
Retroperitoneal fibrosis. And then Travis mentioned the one, and somebody told me about a case today of someone who came in with bilateral ureteral obstruction. It's often associated with pain, but not always. So how many of you have seen patients come in with bilateral asymptomatic kidney stones? It absolutely happens.
I have seen it twice. Someone who came in, it's not that common, but I had someone who came in with gross hematuria the other day and had zero pain, and we're like, oh, that's weird. I want, going through a differential. We're like, maybe it's a kidney stone. Let's scan them. And how do you have a 5 millimeter stone in your distal ureter and have no pain? But it happens.
It happens more than you would think. Okay, so we haven't ruled out post-renal. And so we're going to look at the urinalysis, but we're probably going to go ahead and get an ultrasound of the kidneys, see if there's any evidence of obstruction, and see if this is acute. We had a really good session several months ago with Eric Wallace, where he talked about the value of looking at the ultrasound of the kidneys for size, that if it's a true chronic kidney disease, and we know just from the numbers, this is not yet a chronic kidney disease, that you would have small kidneys. Okay, so pre-renal doesn't sound like it makes much sense. Post-renal still is in our differential somewhere, and we have to rule that out. Then what are the possible primary kidney diseases the patient could have? We have interstitial disease, and what other kind of disease might we have other than interstitial disease? Glomerular disease. And so the urinalysis would really help us a lot. So my retrospectoscope criticism is that with a new serum creatinine of 1.6, we probably need a urinalysis right away. In the old days, and I'm old enough to remember the old days, and I guess you define the old days by me these days, we would look at the urine ourselves. That there was a microscope on every floor, and you'd spin the urine and look at it under a microscope, and some of us knew what we were doing.
We actually did that yesterday. It was actually.
You did it? Yeah, so yeah, the nephrologists still do that, and the nephrologists really learn a lot from that. So we'll get to that. So now the patient has a creatinine of 2.2. My guess is that's when the patient gets admitted to the hospital. Is that right, Gerlene?
I think that was another creatinine before hospitalization, because at the same time, the patient also had an MRI with contrast around that time, which had convoluted some of the things going on in the primary outpatient setting.
And what was the
But
MRI for?
The MRI was for, she was having intermittent leg discomfort in her leg a week or two prior to hospital presentation. So she had an MRI with contrast of the left leg.
Okay, is anybody worried about the MRI with contrast in a patient who has an elevated creatinine? Norma's not worried. There's no such thing as CIN. What's CIN?
I think they mean contrast-induced nephropathy, but what MRI is, they use gadolinium.
Yeah. Okay. So let's. So I think that's a good. This is a good space to mention this. We used to worry a lot about gadolinium in people with end-stage kidney disease causing nephrogenic systemic fibrosis. But the new gadolinium, they seem to be able to use it okay. It was with creatinines in the two level, it was never shown to really be a problem. So that's a totally different contrast than the contrast that we use for a CT. So this is the current belief of most of the nephrologists that I've been talking to is that the dye that you use for CTA, whether it's of the abdomen or for the chest, does not cause acute kidney injury. The amount of dye you have to do if you do an arterial study can cause it. So after cardiac cath, you can get a contrast induced AKI, but probably not with just routine CTs. Does anybody have any other thoughts about that besides me?
This is my love of nephrology is this. So, finding a good study that shows venous contrast induced nephropathy doesn't exist. Most everything are case reports, anecdotal. Hey, I saw this on this person. One of the largest studies and best studies that they've done is more of a retrospective one that they published in Annals of Emergency Medicine about 3 years ago in 2017, where they looked at 16,000 patients, I want to say. Of them, I want to say it was 6% in the group that got contrast and 6% in the group that did not get contrast. Both kind of developed, what they considered CIN. So there really was no difference, and that's been, the largest one that they've been able to do and best study on it. The only caveat to that is they only included patients who had GFRs greater than 30. So under that, I don't know. I just know for venous contrast, if it's above 30, and that's kind of what our radiologists do, that we use it pretty regularly.
Yeah.
But like you mentioned, the arterial stuff, the heart caths, there really isn't a lot of good data that I can put my foot down and say, no, it doesn't.
Okay, so Gerline, let's go ahead and move on. So what I hope we've done is, and if anybody has any questions at this point, what I try to do is, this is how we're thinking about the patient that was normal, then was 1.6, and now is 2.2, and what could be going on. Because if we don't know what could be going on and have a bit of a schema, it doesn't have to be a perfect schema, but a bit of a schema in our heads, then we won't check all the boxes. And it looks like the boxes are, we doubt that we have a volume problem unless something else shows up. We're concerned about an obstructive problem because we're always concerned about an obstructive problem. Hopefully, Josh, this is something that the nephrologists agree with. You always make sure there's not an obstructive problem, because you can fix obstructive problems, and we hope we can fix kidney disease itself, but we can always fix an obstructive problem. Almost, we can figure out some way to address an obstructive problem. Okay, so go ahead, Gerline, and let's see what we do with all this.
Do you want me to provide some of the history before I give the creatinine in the hospital? Or just like
Absolutely. So because I think the history is going to help us interpret some of the labs later on.
Yeah. So when I saw this patient, she was presenting to the hospital with a 2-week history. This was after the primary care labs. So she was presenting with a 2-week history of bilateral back and flank pain, generalized weakness, vomiting. She also had intermittent headaches and was having flashes in the center of her vision bilaterally the morning of her presentation. She also had some associated nausea, fatigue, and lightheadedness. And then I can give the vital signs and then maybe the BMP, and then we can talk a little bit more about some of the other lab results.
So in this one, let's stop after the vital signs, because I think once we
Okay.
get the vital signs, then we can, that may give us some clues to be thinking about what's going on.
Mm-hmm. So the temperature was 36.5, blood pressure 215/91, heart rate 88, respiratory rate 18, and 99% O2 saturation on room air.
So Josh, we got you some really good information here.
Yeah.
What are your thoughts?
With the caveat of 2 days of nephrology, I am sufficiently concerned at this point, especially with a blood pressure that high. This makes me think that there's definitely something going on with the kidneys, and it could be pretty sinister or insidious at this point.
Okay, so one good thing to get, so Gerlin, you'll have to help us with this, is has she had hypertension before?
Oh no, her past medical history is only significant for hypothyroidism and rheumatoid arthritis. No other past medical conditions.
So now we have new severe hypertension. How might that help us?
It makes me think about something intrinsic in the kidney.
Mm-hmm.
That's the first sort of.
So I think as I was thinking through this the first time I heard it, the first thing I thought of was that if she had an inflammatory process in the kidney, that often will cause severe hypertension. The other possibility is this could actually be pre-renal. And this is tricky, but you'll see it every now and then. And so she could have renal artery stenosis. And why would a 45-year-old woman have renal artery stenosis?
The fibromuscular dysplasia?
Yeah, and it could present like this. So that would have to be in our differential, and that's the one time that it really might be pre-renal. And they can present with really high blood pressures, and the problem would be, I guess you'd have to have bilateral to actually have an increase in the creatinine. It's sort of far-fetched, but we need to keep in the back of our mind because that's an awful high blood pressure in someone who's not had hypertension before. It's possible that she would have atherosclerotic renal artery stenosis at age 45. Pretty unlikely, but I think you just have to keep that in the back of your mind, depending upon what's going on. So let's see what her labs were like when she comes into the hospital.
Yep, so the BMP showed a sodium of 138, potassium 4.4, chloride 105, bicarb 23, BUN 34, creatinine 3.7, and glucose 92.
Was she on any medicines with her rheumatoid arthritis?
No, she was not. Her only medication that she was taking was Synthroid for her hypothyroidism. And the rheumatoid arthritis was a presumed diagnosis. She'd seen a rheumatologist and her rheumatoid factor was high at 236. And she had some joint pain and swollen fingertips, but she was not on any immunosuppressive medications.
And had she been taking non-steroidals?
She'd been taking NSAIDs for a couple of weeks, but she had stopped 2 weeks prior to her presentation to the hospital.
Hey, can I ask something?
Please.
What would you, this person comes into the, ER and, she's got those symptoms, this is kind of before her labs come back and, her blood pressure's that high, it freaks everybody out. She's got back pain, flank pain, she's vomiting, headaches, she's lightheaded. Before you get labs back, are we, what are we going to do with her vital signs, I guess?
I'm really glad you asked that question, because I'm going to pick on Kevin because Kevin wants to treat it. What are you thinking, Kevin? What diagnosis are you thinking of?
Well, I discussed the case, so
I know.
I know the answer.
No, but why might you want to treat the blood pressure?
Because I don't want her to stroke out.
Okay, so the question is this a hypertensive crisis? And you could make the case with neurological symptoms that there's enough evidence that this is a true hypertensive crisis as opposed to hypertensive urgency, which doesn't really exist. And and so I think you could make the argument that with the creatinine be going up and having the severe headaches and flashes and visions, that this is a hypertensive emergency, and so lowering it somewhat makes sense. Travis, you mentioned press. Tell the learners about press.
Well, it's had a couple of different names, but it's posterior reversible encephalopathy, and I want to say the mechanism is more of a kind of a dysautoregulation of the cerebral vasculature, and you kind of get leaky blood vessels. It's one of the things, one of the hypertensive emergencies that I'm always on the hunt for, and it's an important one to treat. Blood, everyone's got high blood pressures, but I mean, looking for that, is something that, you can save a life. If someone comes in with a headache and, their blood pressure's high, it's definitely something to have on your radar.
Yeah. So, there's a lot of literature now, and there's just another study that came out showing that using aggressive antihypertensives in hospitalized patients leads to worse outcomes than just putting them back on their home meds. But she was not on home meds, and she didn't have a history, and now she has these symptoms. So I don't think she fits those studies that makes us be cautious about giving hypertensives. Fernand wrote something that I would write, that he hates hydralazine, and I would not use hydralazine. I like the idea of labetalol to start out with. Now, let's go back to the rheumatoid arthritis. This is a presumed diagnosis, and we don't have any, as far as I know, we don't have any evidence of whether she really has rheumatoid arthritis. Is that correct?
So she had seen a rheumatologist in the past who had diagnosed her rheumatoid arthritis because her rheumatoid factor was elevated at 236, but she was not started on any medications, and there wasn't any other information that we had when we saw her in the hospital.
So if she really had rheumatoid arthritis, what would we expect on physical exam?
So for me, as somebody whose wife has rheumatoid arthritis, I would sort of look at the distal joints, specifically in the MCPs, the PIPs. Look at the wrists, the ankles. Ask her about mobility issues in the morning with her shoulders, knees, back, anything like that. Whether she's had any sort of flares, or whether it's felt inflamed, like subjectively, or whether she's noticed it's red or puffy and been warm.
One of the things that has been impressive to me the few times I've had patients, and I mostly work at a VA, so I don't see a lot of rheumatoid arthritis, but when someone does have rheumatoid arthritis and has rheumatoid arthritis in their joints, they have synovitis. Many of the students and residents have not actually felt that before. And for those of you who have not felt it, it's a very spongy feeling. So if you feel your own MCP and PIP joints, you can feel they're very firm. But next time you find a patient who has rheumatoid arthritis, go feel their joints. And before they get the ulnar deviation, you can actually feel the synovitis as sort of being spongy and often painful. And you would expect that in most people with rheumatoid arthritis who had not been treated with DMARDs. That sort of, it makes it hard for me to accept that diagnosis. And somebody in the chat, it tends to be very symmetrical, rheumatoid arthritis. So we have to keep that. Is this rheumatoid arthritis, or do we have to open up the entire rheumatological possibilities? Sean, you're going to be a rheumatologist. What thoughts do you have about this?
So one of them, Dr. Hudebert, had mentioned in the chat already, and I don't know this case, but when I had kind of heard the one-liner, that was the first thing that came to my mind was sclerodermal renal crisis. You can have a positive RF with that. They present with hypertension, elevated creatinine. Still kind of really want to know the UA before I start making too many bold claims.
The other thing that I thought of when I heard the case with a positive rheumatoid factor was what? Because Angela Goffo mentioned that in a case we did at unRemarkable Labs.
I'm not sure if this is what you're getting at, but subacute bacterial endocarditis or infectious aortitis could also have a positive RF.
Or cryoglobulinemia.
Mm-hmm.
If I remember right, that people with cryoglobulinemia often have elevated rheumatoid factors. So the elevated rheumatoid factor is not doesn't really make a diagnosis of RA if you don't have any physical findings to go along with it. I don't think. Is that your understanding, Sean?
Sorry, I froze for a sec. What did you say?
So is that your understanding is just an elevated RA without the clinical syndrome of rheumatoid arthritis? It's kind of hard to make the diagnosis just on serology.
100%, yes.
Because and what we've done is we've given you a differential of what might cause an elevated RA. Okay, let's finally get to the urinalysis.
Yeah, so she did have some like migratory joint pain. I don't remember if I mentioned this today, in her hands and knees associated with the symptoms that she'd gone to see a rheumatologist for. And based on her high blood pressure, actually, like she was presented to the hospital. She was taken to the NICU and she got 2 doses of labetalol and was started on a Cleviprex drip to manage her hypertensive emergency. In terms of the urinalysis, so the urinalysis showed 4+ protein, 3+ hemoglobin, specific gravity of 1.019, leukocyte esterase and nitrites were negative, glucose and ketones were negative. There were 0 to 5 white blood cells and 20 to 50 red blood cells. There were also fine granular casts, but no red blood cell casts. And the urine pH was less than 5.
So aren't you glad you're on the renal service right now?
Oh yeah.
So what does this make you think of, this urinalysis?
So with the caveat of not knowing the test characteristics of RBC casts, their absence makes me think this may not be a glomerular nephritis and maybe looking someplace else. So
Good. So we're going to teach you something. The lab is very poor at finding RBC casts for 2 reasons. Number 1, they have to look at a lot of urines. Number 2, the urine sort of sits around for a long time and sort of decomposes before the lab gets to it. To find RBC casts, I was told this back in the 70s. I think it's still true if you talk to nephrologists, you need warm urine. You need to get the urine and take it straight to the lab. So granular casts and a lot of red cells is good enough for me for glomerulonephritis, as long as she's not menstruating at the present time. But the casts make me think of that. So the RBCs make me think very strongly of glomerular disease and very strongly of glomerulonephritis. What about the 4+ protein?
yeah, that's not good. But as I learned, when you have, in this case, proteinuria and hematuria, the hematuria trumps the proteinuria. So we focus on evaluating her for a nephritic syndrome over a nephrotic syndrome.
Right. And there is a study in the annals, and I actually did a podcast on it, where the dipstick there are formulas to predict how much proteinuria there actually is from the dipstick. And once you get to 4+, it's pretty strong. She does have 20 to 50 red cells. You would probably get a urine albumin creatinine or a urine protein creatinine ratio to see whether or not there was a lot of protein in the urine. So there are different types of glomerulonephritis. So if we're thinking about glomerulonephritis, the other thing that is very interesting about glomerulonephritis, as opposed to a lot of things in kidney disease, is the tubules are still working by the time, even at this point. And notice the specific gravity is rather high. The specific gravity is rather high. If we did a fractional excretion of sodium, it would be rather low. And that is classic for glomerulonephritis because they don't have tubular disease. So the problem is that the glomerulus, but the tubules think that the patient's volume contracted because they're getting less volume through. And so that specific gravity would be more consistent with glomerular disease than interstitial disease, but the red cells and the granular cast probably get that. Now, there are a variety of different types of glomerulonephritis, and we have a lot of people aggressively trying to guess what the glomerulonephritis is in the chat. When I first saw this, I said, looks like significant proteinuria and it looks like glomerulonephritis. So therefore, what pathology would fit that?
Can you ask the question, or can you repeat the question?
Yeah, so it looks like we might have significant proteinuria. And if we can document that there's really significant proteinuria, and we can document and we bring the renal team by, they grab some urine and they see the red cell casts. What pathology of glomerulonephritis would that make you think of?
It's like a mixed nephrotic.
Yeah, or membranoproliferative is what I'd be thinking of. And so it would be I'm sure renal got involved and usually renal would look at that. Now, so what are we going to do to work this up, Josh?
Ooh, so we want to try to figure out, at least the way it was explained to me yesterday, if this is either an immune complex or an antibody mediated cause. So we'd want to look at like viral causes like HIV, hepatitis, and then look at some rheumatologic stuff like the ANA, anti-double-stranded DNA, anti-GBM, and ANCA, and then probably complement levels as well.
Right. So we discussed a case previously with Eric Wallace, and he said, at this point, I hope I'm not quoting him exactly, but the sense I got at this point, we have to screen for everything because you can't tell. The big question is, do you want to do a biopsy?
Probably, considering the rapidity with which she's going down. Oh, actually, no, let me upgrade my answer to a yes, because if she has active disease, they can treat it and hopefully preserve kidney function.
Right. So that is absolutely beautiful, Josh. Why would you do a biopsy? Because it'll impact your management. That's a great reason to do a biopsy. It'll impact the management, and many glomerulonephritides can be controlled in 2021. I assume we got an ultrasound of the kidneys first. Is that right, Gerline?
Yep. So the renal ultrasound showed kidneys of size 12.5 centimeters and 13.2 centimeters with normal cortical thickness. There was a simple renal cyst on the mid-lower pole of the right kidney, but no evidence of hydronephrosis.
Okay, so we got rid of the hydronephrosis with that, and these are normal-sized kidneys, which fits with the story. This is an acute story. Are we surprised? that a patient that we think has glomerulonephritis has hypertension.
No.
We should not be. The one glomerulonephritis that I diagnosed when I was doing outpatient medicine was a 19-year-old woman who all of a sudden developed hypertension. And I looked at her urine and found red cell casts, which killed her chances. She actually wanted to get a go into the Air Force, and that sort of killed her chances for going to the Air Force. So the biopsy should give us the answer, and the rheumatological testing and the complements should. So let's go straight to that. And the whole story starts to fit now. Does anybody have any questions before we go to these rheumatological tests? Okay, Gerlene.
So her C3 was 35.1, C4 was less than 8,
And
ANA,
what are the normals for the C3 and the C4?
I don't have the normals, but I think C3 is normal, C4 is low.
Okay.
ANA was high at 160 with a speckled pattern. Rheumatoid factor was 18, which was high as well. Anti-myeloperoxidase, anti-proteinase, and CCP3 were all normal. She had a negative anti-centromere, anti-cardiolipin, beta-2 glycoprotein, double-stranded DNA, the scleroderma panel, as well as SSA and SSB for estrogens. Coombs was also negative, and cryoglobulins were negative. HIV was negative, Hep A, B, C were all negative. Her IgG level was high at 1524, and IgM and IgA levels were within normal limits. And I don't have the specific types of IgGs, just have the normal IgG overall value.
I think that's great. So the fact that the complement's low, active disease, right?
Mhm.
Are we excited about an ANA of 1 to 160? And are we excited about the rheumatoid factor being positive?
No, I'm not excited about him.
You're not excited about them. So 1 to 160 is in the range that it could be real disease. So the question is, was this rheumatoid factor really, and the migratory arthritis, was this really lupus? And is this a manifestation of lupus? We've successfully made much less likely many things we were worried about. We were worried about scleroderma appropriately because of the blood pressure. We were worried about ANCA-related disease because you always have to be worried about that. We were worried about anti-glomerular basement membrane disease because you have to worry about that. We're worried about infections, which is totally appropriate. I don't think we can discard that ANA just yet. So why don't we do the biopsy and get the reveal, and then I'm going to pick on Kevin and Drew, who discussed this case in a totally different way before, and get some of their reflections on what we've done in the discussion today to try to focus a little bit more on how you think through the labs and how that helps you get to where you want to get to. So well, let's do the biopsy and then we'll have some comments about that.
Yep, so the biopsy showed diffuse necrotizing and percenteric immune complex mediated glomerulonephritis with full house staining pattern. So the wall stained for IgG, IgA, IgM, C3, C1q, C4. And it was consistent with lupus nephritis. There was diffuse tuberointerstitial nephritis, as well as extreme cellular and fibrocellular crescents in around 60% of the glomeruli. An electron microscopy showed electron-dense deposits in the basement membrane, as well as subendothelial and mesangial dense deposits. There was no evidence of vasculitis.
And so what treatment do they use for this in 2021?
So the
Early.
patient received Cytoxin as well as Solu-Medrol and was started on dose of outpatient follow-up with more doses of Cytoxin. So she was also initially started on eculizumab because the preliminary biopsy results had shown evidence of TMA-associated lupus nephritis. However, once she was discharged and the full biopsy came back, there was no evidence of vasculitis on the biopsy, so that was discontinued. And usually eculizumab is it's usually used for like PNH or atypical HUS, but there's been some case reports associating it for treatment of lupus nephritis with TMA. So that's why it was initially started, but the main treatment was Cytoxin or cyclophosphamide.
And do you have any happen to have any follow-up on whether it improved her renal function?
I haven't checked back, but I think it did improve her renal function right now. She hasn't required dialysis or any further treatment right now.
So Josh, why don't you start with your reflections on working through this case and what it taught you?
So it was another reminder to just be a little bit more careful before striking out something from the differential. In this case, it was the post-renal part that I learned, to just be a little bit more diligent and think a little bit more carefully about that going forward in the initial evaluation.
So Drew, you discussed this case before, and we went at it a slightly different way. What going through it this way, what did it add to what you had already heard previously?
Honestly, it made the diagnosis make a little bit more sense. The final diagnosis of lupus nephritis, because when I was going through the case myself, I had sort of had that in the back of my mind. I tried to go from very big, general, broad buckets all the way down. And I had eventually gotten to, it's a glomerulonephritis of some kind. I now have to look at the rheumatology studies to try and figure it out. And when I got the studies, I guess I was a little bit torn because I didn't see like a classic ANA positive, anti-dsDNA positive, like slam dunk lupus diagnosis. And so I sort of hesitated a little bit, but once the biopsy came in, then it was a bit more sure.
Kevin, you discussed this case previously. What did this do for your understanding of the case? Was it worthwhile to go through it a second time?
Yeah, I think it definitely gives a different perspective. When we were going through the case, I remember just getting the initial presentation before knowing anything about the labs, and just trying to think of really what was going to connect everything that she was presenting with. And so I remember thinking initially like something along the lines of like a vasculitis, but just seeing it from a different perspective. Obviously I knew the case, but I think it kind of helped narrow down where the process was coming from a little bit more quickly than it did when we discussed it on VMR. I just think the different perspective and kind of seeing the information in a little bit different order kind of changes your line of thinking on it.
Yeah, to me, the biggest mistake that we sometimes make is we try to look at too many different parts of a case at once. And the money had to be in the kidneys because the kidneys are what's getting worse, and the kidneys can explain the hypertension and explain all the other symptoms. It looks like she had lupus all along. Sean, you're going into rheumatology. What are your thoughts after hearing this case and going through the case?
So one of the things that came to mind is I know she had a positive ANA, but ANA negative lupus is a thing too. And if you see it on your biopsy, like you can trust the biopsy. Lupus nephritis isolated is still lupus. Having that low complement was extremely helpful to kind of point you toward that even before the biopsy. And complement levels can help you with your differential building. So they're not something you should ignore if they're low.
Well, Gurleen, we're very grateful to you for presenting this a second time. I think this was really good space learning because this reinforced a lot of the things that Eric Wallace taught us. And if you were not on that one and haven't looked at it, go back and look at how he explains a lot of these things. I think would be really worthwhile. My great colleague, Dr. Hudebert, do you have voice abilities, Tavo?
Can you guys hear me?
Yes, yes. I'd love for you to have the final word about how you would be thinking through this with your team.
Well, I'm a believer of being very careful how to order tests in patients with RPGN, which I think this patient had, and I probably lean a little bit more on complement levels before I do widespread testing, because all of these tests are false positives results. So low complement levels will have taken me on a different direction that, let's say, ANCA vasculitis.
Mhm.
And this patient probably would have needed a biopsy because the ANA, although it was positive, was a little bit underwhelming. I never heard the results of the double-stranded DNA. Was that positive?
It was negative.
So
It
no.
was negative.
So the biopsy actually is what is called a full house biopsy, very consistent with SLE and with the crescents. I think that you will treat it even if you're not 100% convinced it's SLE. With a therapy that she received. It will be interesting over the next year or so that she fully develops lupus. From studies that has been done at UAB, we know that might take up to 6 to 12 months to people fully develop SLE. She really does not have fulfilled the quote unquote, I know the research criteria for SLE with the data provided, but I would be very academically inept if I wouldn't treat her aggressively with immunosuppressive therapy, regardless of what the final diagnosis might be. And I think that at this point, SLE is the best, although I'm not convinced that I will still keep my eyes open in case this might end up evolving into something else.
Well, certainly rheumatological diseases seem to morph over time. I think Michael Rothberg made a very interesting point, and I think it reinforces what we said before. With the creatinine going up this fast, but not being ATN, and having an abnormal urinalysis, if you hadn't already called renal, by the time you got the urinalysis, you had to call renal. You really have to jump on that, and the quicker you can treat this patient, and you know that this creatinine is really rising quite fast. It's a very rampant disease, and so I think that's a good insight, Michael. Thanks everyone for coming, and especially Gurleen for bringing this case to us. Certainly, Josh did a wonderful job, and good luck on your renal rotation. And we'll see you next week.
Thank you.